Good morning, everybody. I will be talking about basics in critical care and its approach. What is an intensive care unit? The intensive care unit is a distinct organizational and geographic entity for clinical activity and care, operating in cooperation with other departments integrated in an hospital. And what do you do in intensive care? What we do is we use the intensive care to monitor and support patients who are threatened or have got failing vital functions and are critically ill, and these illnesses have a potential to endanger life, so that adequate diagnostic measures can be taken and adequate medical and surgical therapies can be initiated or performed to improve their outcome. So it's a department which is dedicated to medical, nursing, and allied health staff that operates with a defined policy and has defined procedures. It has its own quality improvement program and its own continuing education program, and it has also got its own research programs. It provides an integral service to the hospital, without which many programs which are needed for advanced surgeries cannot function. Surgeries such as cardiac surgery, trauma surgery, emergency surgery, liver transplant, kidney transplant, cardiac transplant, all these cannot function. Who are the people who need ICU care? People who require monitoring and treatment for one or more organ functions which are threatened by an acute disease. It can also be an acute or chronic disease. And what are the common diseases which you see in intensive care? You see patients of sepsis, myocardial infarction, gastrointestinal hemorrhage, and also you may see patients who are being monitored and managed after as a sequelae of surgery, or maybe some intensive interventional procedure like angioplasty or a life-threatening surgery like the CABG. So who are the patients who should get the benefit of ICU care? Patients with existing failure of one or more organs, such as the cardiovascular failure, respiratory, renal, metabolic, or cerebral dysfunction. They are the ones who have got a reasonable chance of recovery. They are the ones who should be kept in the ICU, not people who are just going to be relaxed. And another thing to remember is patients with known end-stage, untreatable terminal illnesses should not be admitted to the ICUs. So what are the patients who are not appropriate for ICU care? Patients with irreversible brain damage, patients with end-stage cardiac, respiratory, or liver disease with no other option but transplantation, but a transplant is not available. Patients with metastatic cancer, unresponsive to chemotherapy and radiotherapy. Patients who are brain dead and are not likely to be organ donors. Patients in coma, which has led them to be in a vegetative state, as in this case, and geriatrics for terminal care. So before you take a patient to the ICU, you should do a triage. Why do you need a triage? You need a triage because ICU beds are limited. And that is why you need to decide which patients deserves to go to the ICU and which do not deserve to go to the ICU. There are triage criteria which have been defined, multiple triage criteria which have been defined. But the following things should be considered while you are going to triage a patient. What is the diagnosis, severity of the disease, age and functional status of the patient? What are the comorbid conditions present in the patient? What is the physiological reserve of the patient? What is the likely prognosis? Is surgical treatment available for that particular thing? Will he respond to treatment with time? Has the patient had a recent cardiopulmonary arrest? And lastly, will he benefit from the ICU care and lead a normal life? The levels of dependency of patients in ICU have been divided into three. Patients who are level 0 require admission in ICU, but they need monitoring for less than 4 hours. There are other types of patients which require monitoring for more than 4 hours because they've got a risk of clinical deterioration. They're level 1. Level 2 is patients which require single organ function monitoring. As for example, patient after a heart attack, he requires a monitoring of his heart function. Then there is the last level, that is level 3. They require advanced respiratory monitoring or support, and their support is of at least 2 organs. That means patient's heart is also involved, the lung is also involved, or the kidney is also involved, depending on the case. What is generally the course of a patient in an ICU? You have to initially assess the patient, thereafter prepare the patient and transport him to the ICU. In the ICU, start monitoring, and thereafter investigate and find out various elements of the patient, do infection control and treatment of infection, and lastly give ventilatory support to the patient. In addition to this, you need to look after the feeding of the patient and the glycemic control of the patient. That means how are the sugar levels of the patient. You need to control that. You need to support the various organs. For example, there's liver dysfunction, support the liver by the correct medication and correct type of food. You give supportive care, you see the progress of the disease, and as the patient improves, you wean the patient off the ventilation and finally discharge the patient from the ICU. This is a lady which is shown who's giving enteral feeding to the patient through a nasogastric tube. Now, we can divide ICUs into, again, 3 types of ICUs. One is the level 1 ICU. Where is a level 1 ICU present? A level 1 ICU is present in small district hospitals. It should be able to provide resuscitation and short-term cardiorespiratory support. It should be capable of monitoring and preventing complications in patients who are at risk due to medical illness or due to surgery. These level 1 ICUs should be capable of providing mechanical ventilation and simple invasive cardiovascular monitoring for several hours. The second level of ICUs are called as the level 2 ICUs. The level 2 ICUs are present in larger general hospitals. They are capable of providing high standard of intensive care, including multi-system life support. And they should always have a doctor on site in the ICU. There should be access to pharmacy, pathology, and radiology. And though it is an ICU, but it may not have access to all forms of complex therapy, such as interventional radiology, cardiac surgery. The doctors working in this level 2 ICU should be certified intensive care specialists. Then we come to the level 3 ICUs. Level 3 ICUs are present in the major tertiary referral hospitals. They are capable of providing all aspects of ICU care as required by the patient for indefinite period of time. Not that they'll be giving care for 2 days, 3 days. They should be indefinite for maybe months if needed. There should be a demonstrated commitment to education and research in these level ICUs. But remember, these large level 3 ICUs are not in one room or one hall. Large ICUs should be divided into smaller pods of 8 to 15 patients, depending on the type of disease which is being treated in that particular level. Now, coming to the designs of an ICU. An ICU requires a very intelligent kind of planning. One must keep the need of the hospital and its location of the ICU and the location of the ICU is dependent on the need of the hospital. One ICU may not cater to all the needs of a particular hospital. That is why you should have multiple ICUs with separate management, and especially so when there are multiple disciplines, and you may have a particular discipline specialist looking after a particular ICU, such as an ICU may be medical ICU, surgical ICU, cardiac care unit, burns ICU, trauma ICU, etc. The number of ICU beds in a hospital range from 2 to 20% of the total number of beds of the hospitals. Generally, in today's world, good hospitals have almost 20% of beds as their ICU beds. It is said that ICUs with less number of patients are not cost effective, while in case you put too many beds in an ICU, they become unmanageable. So you should have the number restricted to 8 to maximum 15. 10% of all the ICU beds should be treated as isolation rooms, or they should be kept in a separate room for isolation of patients who are severely infected. Each ICU should be geographically distinct in the hospital with a controlled access. That means not everybody can enter the ICU. So it should be kept in such a way that it can be controlled. There should be no thoroughfare through the ICU, and only those concerned with the ICU should be able to enter the ICU. The supply and professional traffic must be separated from the public and the visitor traffic. That means the entry and exit points of the doctors and the medical personnel should be separate from the entry and exit points of the visitors, so that there is no mixing and they can easily enter and exit, and visitors are restricted from entering. The organization of the ICU should be so chosen that it is adjacent to, or at least has got easy access with the help of elevator or otherwise with the emergency department, with the OT, with the EDUs, and with the radiology department. In case you need to use corridors, the corridors or the lifts or the ramps should be spacious enough to provide easy movement of the bed and trolley of a critical patient. And not only bed and trolley, but along with that, oxygen cylinders, monitors should all fit into that lift or ramp, whichever way you are using. Very close to ICUs, in modern hospitals, you also have HDUs or high dependency unit. HDUs are specially staffed and equipped areas to provide a level of care intermediate between ICU and a general ward. They are generally located very close to specialty wards or within or immediately adjacent to the ICU complex. They provide intensive monitoring and support for patients with or at risk of developing acute failure. They are somewhere between step up and step down units of levels of care. That means from ICU, the patient goes to HDU and then goes to the ward, or from the ward, the patient goes to the HDU and thereafter goes to the ICU. So they can be step up or step down units. What is an ICU team? The ICU team is very large. It consists of critical care consultants, resident doctors, nurses, physiotherapists, respiratory technicians, pharmacists, primary providers, which is the specialists dealing with a particular disease, technicians, GDS, and housekeeping. In addition to this, we also have ancillary staff such as the dietitian, the biomedical engineer, the computer programmer, social workers, and counselors. Remember, in ICU, as far as nursing staff is concerned, it should be 1:1 for ventilated beds and 1:2 for other patients. The nurse who is in charge of the ICU should have a qualification of ICU training. It should not be just any other nurse, but the nurse in charge should be ICU qualified. Infection control is one of the most important things in an ICU. Hand hygiene must be maintained at all times with either use of hand wash or with use of 60 to 90% alcohol or 0.5 to 1% chlorhexidine weight by volume. In case of patients, the airways must be managed with good sterile orotracheal suctioning. Oral hygiene of patients should be maintained using chlorhexidine 2% or povidone 10% at least thrice a day. Ventilator circuits should be single-use on one patient, should not mix, and should be thrown away when they appear dirty. Suctions again should be very sterile, and there should be no mixing of suctions. The patients are best treated for infection control and prevention of respiratory infection. Patients should generally be always kept in 30 to 45% head up position. As said earlier, infection has to be controlled. So for preparing the skin of the patient, you should use 2% chlorhexidine, which is much better than using 10% povidone iodine. Chlorhexidine and chlorhexidine sequential cleaning is even better as skin preparation for central line insertion especially. The advantage of chlorhexidine is that it tends to stick to the skin and provides long-term protection. The ICUs use what is called as sepsis bundles. That means there are certain bundles which are used. They are as prescribed as bundles. So everybody has to follow that particular bundle for managing the sepsis in a patient in ICU. For example, for septic shock, low dose steroids is administered, or dotricognita alpha activated is administered in accordance to ICU policy, or glucose is maintained less than more than 150, around 150 ml, milligram per deciliter. And we should also ensure that the ventilation in a patient in sepsis should be maintained in such a way that the plateau pressure of the ventilator does not exceed 30 centimeter water. There are also antibiotic care bundles in an ICU. The antibiotic prescribed to the patient should be appropriate for the patient and should be done after culturing the sputum or whatever infected area from the patient. It should be cultured, the blood or a blood culture should be done to decide which antibiotic to prescribe to the patient. In case you're doing a blood culture, you should always take 2 blood samples from 2 different sites before deciding it's a contaminated blood culture or is it an actual growth in the blood. We may initially give empirically antibiotics, but later on, we should always follow the culture report and give antibiotic accordingly. There should be a daily review of the antibiotic choice and its continuation. Patients in the ICU need sedation because it's a very disturbing kind of atmosphere. Fentanyl is generally used nowadays as sedation, and what we generally follow is we make a solution of fentanyl with 500 micrograms in 50 ml normal saline, and we give it at an infusion rate of 2 to 5 ml per hour. That is about 20 to 50 microgram of fentanyl per hour. At times, we combine midazolam with fentanyl. In case of midazolam, we add 5 milligram midazolam to this 50 ml of fentanyl and give it at an infusion rate of 2 to 3 ml per hour. Patients who are post-operatively there in the ICU, they may be on mechanical ventilation and they may be on an IV infusion of fentanyl along with propofol or dexmedetomidine alone. So it will depend on the patient that how we give sedation, but sedation has to be given to a patient in the ICU. In the ICU, we should also ensure that we should give the patient prophylaxis against stress-related mucosal disease. That is, prevent patients from getting gastric erosions and ulcers. The most common drug used is intravenous ranitidine, 50 milligrams 8 hourly. We can also give ranitidine 50 milligram 12 hourly in patients with renal failure. IV H2 antagonists are better than using sucralfate. And even proton pump inhibitors, PPIs, as prophylaxis are not superior to H2 antagonists. So that is why we should prefer using H2 antagonists. We can use IV omeprazole and IV pantoprazole 40 milligram daily, also is possible. But as far as possible, try to use only PPIs. And in case the patient starts tolerating oral therapy, you can change over to oral PPI prophylaxis. Coming to venous thromboembolism prophylaxis. All patients in ICUs should be assessed for likelihood of venous thromboembolism. In case the platelet count decreases to less than 30 to 50% of the initial amount, or it becomes less than 1 lakh per microliter, or the INR becomes more than 1.5, we'll have to withhold the heparin which we are using for thromboprophylaxis. In case of neurosurgical patients, generally they avoid heparin and they tend to use mechanical prophylaxis methods. But even in those patients, it is safe to use heparin products after 48 to 72 hours of neurosurgery. As I said earlier, the common method of giving prophylaxis is using low-dose unfractionated heparin. The dose generally given is heparin 5,000 international units subcutaneous 8 hourly in patients who are at high risk, or 12 hourly in patients who are at moderate risk. You can also use low molecular weight heparin, LMWH, and LMWH is generally given as subcutaneous, for example, enoxaparin, 40 milligrams daily when creatinine clearance is less than 30 ml per minute, or 30 milligrams daily when the creatinine clearance is greater than 30 ml per minute. In patients who are at high risk of thromboembolism, in those patients, we should give at least enoxaparin 40 milligrams every 12 hours. Some patients may be on epidural catheters, or you may need to insert an epidural catheter in the ICU. We have to remember that epidural catheters cannot be inserted in patients who are on anticoagulants. So we should wait for at least 12 hours prior to removing the epidural catheter. After the dose of LMWH, we should wait for 12 hours. After the removal, we can restart LMWH 2 hours after the epidural catheter has been removed. We should routinely screen all patients for asymptomatic deep vein thrombosis. But it should not be very thorough screening like a scan. The advantages of LMWH over other methods of providing anticoagulation for prevention of VTE is that's a once daily administration. It has greater bioavailability, lower incidence of heparin-induced thrombocytopenia, and it is very cost effective due to less amount of laboratory monitoring. Coming to circulatory support. The vasopressors needed for hypotension vasopressors are needed for hypotension in case the patient does not respond to fluid resuscitation, because we have to maintain a mean arterial pressure of at least greater than 65 millimeters of mercury. So in case hypotension persists despite fluid resuscitation, especially in patients with septic shock, or the lactate levels rise to greater than 4 millimole per liter, it indicates that the patient has gone into low cardiac output and the patient is not getting adequate oxygenation in the tissues of the patient. The adequate oxygen is not reaching the tissues of the patient. So you should target to initially resuscitate the patient with fluids to get to an CVP of at least 8 millimeters of mercury. And we should target to get a central venous oxygen saturation to greater than 70%. What are the common drugs we use for circulatory support of such patients? We can use inotropes such as adrenaline and dopamine. We can use vasopressors like noradrenaline and phenylephrine, or we can use ionodilators like dobutamine, milrinone, amrinone, or levosimendan. What are the fluids used for circulatory support? The common fluids used are normal saline, balanced salt solutions, and colloids. Now, what is recommended today is to use more frequently balanced salt solutions like ringalactate, plasmolite, cavilite, and sterofundin. You can also use colloids in case there's an acute emergency or the fluid has to be given immediately because of hypovolemic shock. You can use colloids like Voluven, Volulite, Gelifuscin, Dextrans, and Himaxil. Most ICUs commonly use only normal saline, which is not a good practice. You should use all solutions depending on the requirement of the patient. Coming to management of myocardial dysfunction and arrhythmias. In a number of patients in the ICU have cardiac dysfunction. You need to give them medication to reverse or limit myocardial injury and manage the entire spectrum of arrhythmias which may be there. The commonest drug used in the ICU for managing arrhythmias is amiodarone. Patients in ICU may require cardiopulmonary support, which includes ECMO, that is extracorporeal membrane oxygenation. They may even require intra-aortic balloon pump if their function of the ventricle is not very good. Patients in ICU will need airway management. Because of sedation, poor oxygenation because of disease, and poor neurological state, they may need to secure the airway of the patient. What do we mean by securing the airway? That means we put an endotracheal tube or thereafter put the patient on mechanical ventilation. So for that, we need to urgently evaluate the patient and manage the airway accordingly. The management of the airway may not be limited just to tracheal intubation. We may have to do a percutaneous tracheostomy on the patient, or we may even have to do bronchoscopic evaluation of the patient and bronchial lavage, depending on the how much of the airway and which part of the airway is needing care. Respiratory support needs to be given to such patients, and that is commonly due to multi-organ failure. We may have to give invasive or non-invasive ventilation to the patient. Patients need sedation to tolerate mechanical ventilation. At times, they also need muscle relaxants to tolerate mechanical ventilation. Sedation is commonly given with fentanyl, propofol, midazolam, and dexmedetomidine. There's a need to prepare these patients, and there's also a need to prepare these injections to give to these patients, and thereafter monitor the side effects or the effects of the drugs. Patients commonly also need analgesia support, that is support from pain or pain management in the ICU, especially patients who are post-operative or have had a trauma. Analgesia may be given in form of a regional nerve block or as an intravenous infusion or epidural infusion. Intravenous infusions are generally given with fentanyl, morphine, or some other opioid. Epidural infusions are given with local anesthetics, and to that we add additives. The local anesthetics commonly used are bupivacaine, ropivacaine, and lignocaine. If the patient's brain is also involved or has had a brain surgery, then the patient also needs neurological support. We need to evaluate the neurological state of the patient regularly and manage the patient in such a manner to optimize the blood supply of the brain and the spinal cord, and to reduce or minimize the outcomes of neurological impairment which the patient has. The patient may have neurological impairment also due to electrolyte imbalance, hypoperfusion or less blood supply, and because of increase in the intracranial pressures. Patients with neurological disease generally need blood pressure optimization and vasospasm management. What I mean by this is that their blood pressure may have, in case it is high, will have to be controlled. If it is low, it has to be increased. And patients who have got something like aneurysms in the brain, they need some drugs which will relieve the spasm of the arteries supplying the brain. These patients may also require targeted temperature management as appropriate for the case, especially after cardiopulmonary resuscitation, they may need cooling so as to preserve the brain. We have to give appropriate amount of physiotherapy in patients, if supposing, especially if they have undergone some hemiplegia or quadriplegia. Nursing care is needed to prevent bed sores. Coming to electrolyte imbalance. Imbalance of sodium, chloride, potassium, magnesium, and calcium is very commonly seen in the ICUs. In case the patient has got hyperkalemia, that is high increase in potassium levels, it may cause bradycardia and sudden cardiac arrest. This needs to be treated with the help of insulin and glucose. If the patient has got lower levels of potassium, that is hypokalemia, he may need supplementation of potassium. And he needs supplementation of potassium. He needs to be on continuous ECG monitoring when the supplementation is on. In case patient has low sodium values, that is hyponatremic, the patient will have neurological deficit or will behave abnormally. Such patients will need salt capsule, which may need to be supplied by the pharmacy. The liver and the kidney also need to be supported in the ICU because acute kidney injury and liver injury are very common in the ICU due to poor general condition of the patient. So you need to start and manage renal replacement therapy, RRT, or you may have to do a dialysis on the patient as required. In case the patient is having hepatic failure, we have to treat hepatic failure or liver failure. Nutrition support cannot be avoided in an ICU because the patient is deprived of nutrition during that period, as the patient is unable to eat properly or is not permitted to eat. So 40% of adults who are critically ill have a high risk of developing malnutrition. And this malnutrition further increases the incidence of mortality and causes poor prognosis in these patients. Supplementation of nutrition is thus very important, and this supplementation can be done by the enteral route, that is through the mouth and the intestines, or through the parenteral route, that is IV. Enteral nutrition is cheaper, safer, and more physiological. Parenteral nutrition is very complex, requires special clinical knowledge, skills, and practice to avoid errors in prescribing, compounding, and clinical management of patients. There may be some ICUs in which the pharmacist is asked to prepare the parenteral nutrition. The parenteral nutrition basically consists of proteins and oils, and they need to be prepared in a particular combination as defined by the dietitian and the intensive care specialists. Shock in the ICU. Patients in the ICU are commonly in a state of shock. What is shock? Shock is a lack of blood flow or perfusion to vital organs, which results in end organ damage. It can result in kidney injury. It can result in delirium, syncope in the brain. It can cause cardiac ischemia, that is less blood supply to the heart, acute liver injury, or gut ischemia or ischemia to the intestines. Septic shock is more common in the ICUs, and it is a distributive kind of shock. The other types of ice shock which are seen in the ICU are neurogenic shock, cardiogenic shock, and hypovolemic shock. So what is the role of a clinical pharmacist in the ICU? ICUs today are changing. They are becoming more and more complex, and the environment is more and more costly. Pharmacy is the norm in ICU. Too many drugs are on in a patient, and medications are frequently used in combinations involving ever-changing doses based on physiological responses of the patient. And this can cause critical illness-related organ dysfunction. This is a perfect scenario for a storm, or it is right, and you can always have multiple medication errors in the ICU because of too many drugs being used and too many changes at all times. A European study conducted showed that 1,000 out of 1,328 patients, they showed that in a 24-hour observation period, 81% of ICUs reported at least one parenteral medication error, and that involved 37% of the patients. The clinical pharmacist in the ICU has a big role in reducing medication errors, and costs also need to be well established. A landmark study in 1999 showed that pharmacist assistants or attendants in the ICU rounds reduced the rate of preventable adverse drug reactions by 66%. Critical care pharmacists are a valuable resource in providing education to clinical team members. In a neonatal ICU, it was shown that a pharmacist-led staff education risk management program reduced medication errors from 24.1 to 5.1 per thousand neonatal activity days. That's a big reduction because of the presence of a pharmacist in the ICU. So what is the role of a pharmacist in the ICU? A critical care pharmacist can lead and participate in clinical research in the ICU. They can also be involved in administrative and leadership type of roles such as quality improvement in the ICU. And literature has demonstrated the ability of an ICU pharmacist to improve financial, clinical, and process outcomes. However, the adoption of what I am saying is very low in ICUs. Hardly anybody is using a clinical pharmacist in the ICU. So what is the current status of clinical pharmacists in the ICU? Critical care pharmacy is recognized as one of the most advanced disciplines in pharmacy practice, and the field is expanding both in terms of quality and quantity. However, ICU pharmacists are not present in institutions that have ICUs. Even in countries such as US and Canada, it is not well developed. ICU pharmacy concept is not well developed. We need a more active participation of pharmacists in ICUs. Thank you very much.